Coronary artery disease is the single leading cause of death in America. It is responsible for 400,000 deaths per year. Just to put that in perspective, influenza accounts for 20 to 25,000 deaths. Motor vehicle accidents account for about 36,000 deaths. Think about how much time we spent learning cervical carcinoma. It is responsible for less than 5,000 deaths. So it's really quite an extraordinary problem. It accounts for 1 in every 6 deaths in America. If we compare that to stroke, stroke has about 160,000 deaths per year. If we combine coronary artery disease and stroke, then that gives us our cardiovascular disease, which is clearly the commonest cause of death in the Western world. Through most of my career, I'm about 65 now, there's been a profound drop in the incidence of coronary artery disease. And there's a reason for that. The first is we've had really powerful new tools in prevention. This has included a huge public health campaign to decrease smoking. There's been widespread application of lipid screening. As well, there's been really profound new treatments. Some of the treatments that really didn't exist back 20 or 30 years ago include the statins. They include angioplasty. And they include all of those marvelous implantable defibrillators and pacemakers. But for your generation of doctors, you're going to see an increased incidence. And you're going to see a new increase in incidence for a number of reasons. The first is going to be our obesity epidemic. Obesity is a major risk for multiple disorders, and that includes atherosclerosis. There's going to be a marked increase in diabetes mellitus type 2, itself atherogenic. This is a society where everyone now sits at home watching television, playing video games, and in and of itself, inactivity is a risk for coronary artery disease. And then the last is, as the baby boomers age out, we have a lot of elderly people, and old age is an independent risk factor. So a disease that's been showing dramatic declines over the past decades is going to show a marked increase for the next generation of doctors. It's important that we understand the public health issues involved in the number one cause of death in America. The first thing we should talk about is risk factors. Remember, a risk factor is what is the likelihood you will have an event in the future. These, of course, start always and ever with atherosclerosis. So when you see the word atherosclerosis and the cause of that, you should immediately think of lipids, hypertension, and diabetes 1 and 2. A subset of all this is going to be metabolic syndrome, that constellation of signs and findings that include centripetal fat found over the abdomen, abnormalities of lipid that consist of increased triglyceride and decreased HDL, hypertension, together with insulin resistance, which we can think of as type 2 diabetes. Other risk factors for a coronary artery disease event include any sign of left ventricular hypertrophy. And obviously the commonest cause of that is going to be hypertension, but it can include other things like bicuspid aortic valves. An independent risk factor is an elevated homocysteine. This is an empiric observation without a known pathophysiology. And then the one that is the single greatest predictor now is going to be coronary artery calcification. And this is a wonderful new test that one can do a dedicated CT image of, because the presence of calcification in the coronary arteries is a marker of degenerative change, and therefore the commonest degeneration is atherosclerosis. So coronary artery calcification is a great marker for atherosclerosis and denotes a patient at high risk that should be evaluated. When we talk about risk, what do we mean? How do we calculate the risk? And the calculation is always defined as the risk for atherosclerotic cardiovascular disease. And believe it or not, it's calculated as the likelihood of having an atherosclerotic cardiovascular event over 10 years. And if the risk is greater than 7.5%, that's considered a high risk. And if the likelihood of an event is less than 5% over 10 years, then that's considered a low risk. It's a surprising little difference, isn't it? But these are the patients that we're going to really aggressively treat, whereas low risk is something that is much less aggressive in our anticipatory treatments. Stable plaque. The hallmarks of a stable plaque are a thick fibrous capsule, very little inflammation, and it has no areas of necrosis. And therefore it is completely silent until it gets to 70%, when it's not going to allow the artery to dilate up enough to meet the demand. At 70%, we get our demand ischemia, meaning we're going to see it with exercise. And we're going to see it again at 90% because then it is at rest. So the pathology of stable angina is a very predictable pathology of stable plaque, and therefore we're going to see it as pain that is related to exercise induction and relief with rest. Ischemia is the balance of supply versus demand. Then how do we measure those? Well, remember we talked about wall stress, and wall stress is left ventricular end diastolic pressure or volume, and that's proportional to the internal pressure, which we can think of as blood pressure, times the diameter of the chamber over the thickness of the heart. So that's one thing that regulates demand. Next is going to be heart rate, and the last one's going to be contractility. Well, how would I look at any of those in a clinical setting? Well, we don't really have a test for wall stress, and I don't know how to do contractility, but I do know how to do a couple of these things. I can take a look at blood pressure here, and I can pick out heart rate here. Those are two good ways of predicting in a nice stable plaque when the patient's going to get chest pain, because blood pressure times heart rate gives us a nice good approximation of demand, and so that's called the cardiac product. That patient will have a very predictable onset of pain when they have predictable demand, so they can tell you they walk up the hill behind their house and they always get the pain about the oak tree and they rest and it goes away. So that's a really good way of thinking through how we measure demand in a pathophysiologic sense. When the patient walks in the door and they have chest pain that sounds a lot like angina, how do we establish the diagnosis? It's a demand ischemia. So you can't diagnose it at rest because there's no pain. The standard tool is going to be an EKG. It's only going to be positive while the pain is there, but otherwise the pain will go away. Typically we have to induce demand before we can see the ischemia. And when we do our standard stress test, like a treadmill, it's not a great test. It really only has a sensitivity of about 65% and a specificity of about 80%. So it's not a bad test, and on exams will always give you a positive result, but in real life, it's just not that great a finding. In the EKG, here's our standard EKG with our P wave, PR interval, QRS interval, and then our ST segment. The magic area, of course, is in the ST segment, which will go up in myocardial infarction, so that's not what we're talking about here. Here it's going to go down. So ST depression is the hallmark of ischemia, and then the other thing we'll often find is inversion of the T waves. So the classic finding is going to be ST depression of greater than 2 millimeters and T wave inversion. And when we talk about that ST depression, remember it has to have the right shape. So if we're coming off our QRS complex here, it's got to be down and either flat or sloping downward. If you have it sloping upwards, that's not normal, but it's not diagnostic of ischemia. That doesn't prove it. It has to be further investigated. Some of the other tests that we have other than the stress test is you can stress the person during an echo and show that the wall becomes stiff and non-viable. There are lots of nuclear tests that you'll learn about when you get further on into clinical medicine. You can stress the heart with drugs, so there are pharmacologic stress tests for patients who can't exercise. But at the end of the day, the gold standard, and the other way of saying gold standard would be criterion standard, is going to be our angiography. And the rule for angiography is significant at greater than 70% and at rest greater than 90%, and everything after that becomes a discussion. Anyone with these abnormalities will get treatment of opening up that obstruction. Thinking through how we treat stable angina is a really great exercise in pathophysiology. Remember, when we're treating stable angina, we're really only treating the symptoms. We're not treating the underlying atherosclerotic obstruction, typically in the proximal coronary artery. And so we come back to our discussion. This should be pretty familiar in your mind now. It's a good way of thinking about ischemia. Demand is going to be O2 content, think anemias. It's going to be flow, think R to the fourth. And that's going to be driven by demand, wall stress, proportional to P, think blood pressure, times the radius of the heart chamber divided by the thickness, heart rate, and then contractility. And contractility is proportional to intracellular calcium. Then when we come down, we can take a look at the drugs that we use to treat it, and we can come back up and say, well, which of these parameters does it affect? The drugs start with our beta blockers, organic nitrates, and these are going to be divided to organic nitrates we use in the acute setting, which is going to be nitroglycerin, versus those we use in the chronic setting, which are going to be our isosorbide dinitrates, calcium channel blockers. This is going to target our voltage-gated calcium channels. And these are going to be divided into two groups. Those that are cardiac selective, drugs like verapamil and diltiazem, versus blood vessel selective, and this is going to be dipines. The last sort of odd one that stands out as its own drug is renalizine, and that has its own unique mechanism. So let's go back and take a look at these as a pathophysiologic exercise. Let's do our beta blockers in red. Our beta blockers are going to decrease heart rate at the level of the conducting system, think SA node, and decrease contractility at the level of the contractile myocyte. So they're really great drugs for treating this. If we take a look at our organic nitrates, and in this we have our endothelial cells, which sit on top of our smooth muscle cells. The endothelial cells produce the local control of vasoconstriction and vasodilation, and one of their tools for vasodilation is nitric oxide. Nitric oxide is going to increase cyclase, which converts cyclic GTP into cyclic GMP, and that decreases our intracellular calcium, and that then is going to decrease our contractility, and so that's going to be very effective for the demand from the myocyte. But over at the level of the blood vessel myocyte, it's going to decrease our wall stress by decreasing our left ventricular end diastolic volume through the venous dilation. Calcium channel blockers are going to be critical for decreasing our wall stress by decreasing left ventricular end diastolic pressure from the venous system. They decrease our contractility at the level of the myocyte, and they might even dilate out our coronary arteries to get a little increased flow there. The mechanism of action of renalizine is somewhat controversial, but it's felt to decrease our intracellular calcium. So that decreases contractility, decreases heart rate, and causes some venous dilation. That brings us to the end of the discussion of epidemiology, ischemic heart disease, and stable coronary artery disease. See you at the next lecture.